Good morning. Yeah, I'm Robinah Nakawunde, a PhD candidate at Stellenbosch, that is in South Africa. So this study is titled Diagnostic Accuracy of Xpert MTB RIF Ultra or Nasopharyngeal Swabs in Adults with Presumptive TB in Cape Town, South Africa. Disclosures, I have nothing to disclose, and that will be the outline for the presentation. Just to remind us, according to WHO, TB is still the leading infectious cause of disease and death globally, with 10.8 million incident cases in 2023 and about 1.25 million deaths. And of all these deaths, at least 13% were in people living with HIV. However, 2.7 million people with TB were either undiagnosed or unreported that year. That's about 25% of the reported burden. And among all those that were either reported or diagnosed, only 60% were bacteriologically confirmed. So as we can see, the diagnostic gap in the TB care cascade is still a deterrent to achieving the NTB goals. So the WHO molecular diagnostic tests like ULTRA have revolutionized TB testing. However, these tests are all primarily validated on sputum. Sputum as a sample has several limitations. It can be quite hard to collect and process. It also requires particular laboratory facilities that might not be available. And some patient groups, especially children and people living with HIV, might not readily expectorate. Thus, there is a need for alternative samples. Nasopharyngeal swabs, however, are a very attractive alternative, as we saw during the COVID pandemic. They are non-invasive, they are relatively easier to collect, and also potentially, if we had another viral epidemic, we could potentially use nasopharyngeal swabs for both viral and TB testing, and that would ensure that the TB testing goals are not, they do not lag behind viral testing as we saw in the last pandemic. But also, as Prof. Grant highlighted, that even if the swabs had maybe showed lower sensitivities, because of the very good sample attributes, they have a potential for a high diagnostic yield. So this study was based on this study among other studies. So this study was published in 2022. It was performed in Tanzania, and it evaluated nasopharyngeal swabs in postmortem samples. So accuracy of ULTRA on nasopharyngeal swabs collected from postmortem participants or deceased people. So as I said, yes, the study population was mainly pediatric and adult medical deaths. So they managed to enroll 219 participants, 27 of whom had confirmed tuberculosis. However, sensitivity was 70% with specificities of 99%. The main recommendation of this study was to evaluate these swabs in living subjects, and that's what we did. So the aim, the main aim of this study was to evaluate the diagnostic accuracy and yield of ULTRA on nasopharyngeal swabs in people with presumptive TB, with objectives to calculate both sensitivity and specificity of nasopharyngeal swab ULTRA in these people, and also to calculate the diagnostic yield. Methodology, so we mainly used biobanked samples. So previous studies had collected nasopharyngeal swabs from adults with presumptive TB, and these had been stored at -20 degrees. So these are the samples we retrieved and tested in this study. So for both the TB positive and the TB negative group, we stratified them by HIV status at a ratio of 1:1, balancing both groups. A little bit of the workflow. So we had different types of swabs. We had inert swabs and dry swabs. Inert swabs were stored in about 2 mL of a universal transport media, but the dry swabs were in an empty microcentrifuge tube. So these were retrieved, thawed, and heat inactivated prior to testing For inert swabs, since they were already in a solution, we tested 1.5 mils of that solution, added TE buffer, and tested using ultra as per manufacturer's guidelines. And for dry swabs, we added the buffer prior to testing as above. Looking at participant demographics, so MRS positive is microbial reference standard, which was sputum culture. So sputum culture positive and sputum culture negative, the p-values compare those two. As we can see, generally people who were TB positive by MRS were relatively younger. They were more likely to be male. They also had lower BMIs compared to the TB negative counterparts. The HIV status was well balanced between the two groups. As I said, we stratified by HIV, and also TB scores were higher in people who were HIV positive, who were TB positive, as to be expected. So when we look at the diagnostic accuracy of ultra, overall, ultra nasopharyngeal swabs showed sensitivities of 34% when we used microbial reference standard and 33% when we used extended microbial reference. The extended microbial reference had both sputum culture and sputum ultra. So someone was labeled TB positive if either was positive. So either a positive culture, a positive ultra, and you were negative if both were negative. As we see, there was no difference when either reference was used. However, on further stratification by HIV status, we can see that HIV negative people had slightly higher sensitivities than HIV positive people, and that differences were significant. But when we compared smear positive and smear negative, you can see that there was no significant differences in sensitivities. Specificity, on the other hand, specificity was 88%, and that was the same when we used either MRS or EMRS, and it did not differ when we stratified by HIV status or smear status, but even previous TB. So sensitivity was similar in people with previous TB compared to those who had no previous TB. Our discussion, so nasopharyngeal swab ultra had sensitivities of 34% with specificity of 88%. Diagnostic yield among all those diagnosed was about 40%, and diagnostic yield among all those tested was 22%. These results were compared to ultra on other non-sputum specimens. We saw some studies where they did ultra on urine, but this was done on only HIV positives, and sensitivities was about 32%. And for blood was also evaluated mainly on people who are HIV positive, low CD4 counts. And also sensitivity was about 37%. Those are just some definitions. So our study had some strengths and weaknesses. Strength, as far as we know, it was the first one to evaluate nasopharyngeal swabs in living subjects, but it also included equal numbers of HIV positives and HIV negative, utilizing both microbial reference and extended microbial reference standards. However, among the weaknesses, we used biobanked samples, which could have affected our sensitivity, but we also, because we pre-selected participants by both HIV and TB status, the results do not fully reflect the true disease prevalence. The conclusion from this study is nasopharyngeal swab Xpert Ultra could offer a promising non-sputum alternative, especially when we cannot obtain sputum. However, we recommend that further investigation and optimization should be done, especially in either people with post-bacillary disease or those that do not readily produce sputum, like people living with HIV and children. I will acknowledge my very nice research team and all our funders. Thank you.